All right, so let's start off with the cardiovascular 4. Let's see. Hold on 1 second here. Hold on, just one quick thing here. Share screen, and there we go, and there. All right, are you guys able to see that first slide? Are you guys able to see the cardiovascular slide?
Yes.
Okay, good, good. All right. Okay, so what have we covered so far with the cardiovascular system? We've covered the heart, basically the anatomy of the heart, the chambers, how blood moves. We've spoken about kind of the mechanics of the heart, systole, diastole. We've spoken a bit about stroke volume. Obviously, one way of evaluating the heart is measuring stroke volume, cardiac output, and heart rate. And we've discussed different aspects of how it's regulated, how we need the respiratory pump, how we need the skeletal muscle pump, and the overall role of venous return in making sure blood gets back to the heart to ensure that you have a sufficient end diastolic volume, right? Which is that's the amount that fills up in the ventricle. The greater the end diastolic volume, the greater the venous return, the greater is going to be your stroke volume. We spoke a bit about the cardiac cycle, the different phases of it, and the status of the different valves, what's open and what's closed. And the key aspect of the cardiac cycle is blood is always going to move in the direction of a high pressure to a low pressure. So if you want blood to go from the ventricle out of the heart into the blood vessels, you need the pressure inside the ventricles to be greater than in the arteries to force the valve open. Until that pressure is great enough, the valve will stay closed. So it's all pressure driven. This right here is kind of a nice little diagram showing blood flow and the different parts of the heart, and you can kind of see the direction of it. It's kind of weird how it's kind of set up, but let's start kind of at this point with pretend this is the left side of the heart. And if you remember, the left side of the heart receives blood, oxygen-rich blood from the lungs. That's why it's kind of, excuse me, reddish, via the pulmonary veins. So the pulmonary veins bring oxygen-rich blood to the left atrium. When the pressure gets high enough in the atrium, it forces this mitral or the bicuspid valve open, forcing blood into the left ventricle. When the pressure gets high enough in the ventricle, the bicuspid valve closes, and eventually this semilunar or aortic semilunar valve opens, forces blood into the aorta. And of course, the aorta delivers blood to all the different organs in the body. But one of the things we're going to focus on in this lecture is the different types of blood vessels. Besides what we have is, of course, the aorta is the artery. As you get further and further away from the heart towards the organs, those arteries branch off into arterioles, which are small arteries. And then once we get to the tissue where the oxygen is going to be delivered, we have these very microscopic capillaries. After the oxygen is dumped off, and conversely, carbon dioxide from the cells moves into the blood, this is carried from the capillaries into these small veins, which are called venules. And of course, this is blue because it's oxygen poor. From the venules, blood then travels through the veins, and you remember these valves, which are important in driving blood back to the heart. The main veins involved in delivering blood back to the right side of the heart is what we call the vena cava. Remember, we have the superior and inferior vena cava that bring blood from the right side or from the head and neck area as well as the lower extremities to the right atrium, pushes the tricuspid valve open, into the right ventricle. When the pressure builds up in the right ventricle, it forces the pulmonary valve open. This then carries blood into the pulmonary artery, which then delivers it to the lungs, where we breathe out carbon dioxide, breathe in oxygen, and then the whole cycle starts all over again. So really the focus of today, so you guys already know that, the pattern of blood flow. Today we're going to take a look at the structural differences, functional differences between veins, arteries, arterioles, venules, and capillaries. All right. So if we take a look at the 5 different classes of blood vessels, let's kind of break them down a little bit. First of all, if we take a look at arteries and arterioles, these are the vessels that, of course, are carrying blood away from the heart. One way to remember that is it starts with the letter A. Think of away. In the systemic circuit, these arteries and arterioles are carrying oxygen-rich blood. In the pulmonary circuit, the arteries, like the pulmonary artery, is carrying oxygen-poor blood. So that's kind of something important to remember about the 2 different circuits. The capillaries, no matter which circuit, pulmonary or systemic, capillaries are the site of gas exchange. When I mean gas, I mean carbon dioxide and oxygen. You could also expand on that, nutrient and waste exchange as well. From the capillaries, blood then moves into the small veins, which are known as venules, and then eventually into the veins. And of course, these are carrying blood back to the heart. In the systemic circuit, they carry oxygen-poor blood. But in the pulmonary circuit, they carry oxygen-rich blood. So that's kind of just something important to remember. All right, so we mentioned these different arteries. We have arteries and arterioles that both carry blood away from the heart, but why do we call them 2 different names? Well, let's take a look at this diagram, which really shows kind of like a side-by-side comparison between arteries, we call, hold on a second here, you can see that. Yeah, between arteries and veins, arterioles and venules, and capillaries. We're going to skip this middle one, medium-sized vein and muscular artery. We're not going to cover that. So we're just going to cover the top, and then the venule and arteries, arterioles, and the capillaries. So let's take a look at the structure. What's actually different between an artery and a vein? Well, first let's take a look at the similarities. Both arteries and veins, histologically, you guys are familiar with histology, of course, we slice through them. Both arteries and veins have 3 layers of tissue that surround the lumen, the central cavity. The 3 layers are the innermost layer, which is known as the tunica interna. It's kind of an easy one to remember, tunica interna. Some books also call it the tunica intima, but either is fine. That layer consists primarily of simple squamous epithelium, a very flat cell in both. The one difference in the tunica interna is in the arteries, you also have an elastic layer, which allows the arteries to kind of expand and stretch and recoil, kind of like a rubber band. So they both have simple squamous epithelium, but the difference is arteries also have elastic tissue. Then we move out to the middle layer. The middle layer consists of smooth muscle, and it's known as the tunica media. Think of media meaning like the middle layer. Now, when you look at this picture, this is the tunica media here in the artery, and that's it in the vein. Which one has a thicker tunica media? Any thoughts?
The artery.
Artery. And that's very significant. It's because the blood that's flowing through the artery is under a tremendous amount of pressure. So you need a very thick musculature to be able to withstand that pressure. A vein, you have a smaller, a very thinner tunica media. Let's go to the outer layer. The outer layer is known as the tunica externa, and that's primarily made up of connective tissue that helps to kind of just maintain the shape, the integrity of the vessel itself. So other than the fact that it's a little bit thicker in a vein, basically structurally it's the same. And we'll talk a little bit about the significance of these difference in layers. All right, so let's jump down now to the venials and arterioles. Like I mentioned, we're going to skip this area. It's pretty much the same, but little differences, so I'm just going to kind of ignore it. Let's go down to the arteriole. So from the arteriole, this is when we see quite a dramatic change from 3 layers of tissue down to 2. We have a tunica intima, which is made up of the endothelium or simple squamous. And then we have the tunica media. You notice it's a much smaller vessel, and I'll talk about why that's significant. And it only has 2 layers, the tunica intima and the tunica media. If we look at, by comparison, the venial also only has 2 layers, but it's different. The venial is lacking the tunica media, so there's absolutely no muscle. It just has the endothelium, which is the tunica interna, and the tunica externa. So that's the difference between those 2. And like I mentioned, I'm going to describe really the significance of these. Finally, we reach the capillary. And the capillary, we've lost an additional layer, and all we're left with is this tunica interna or endothelium. And the reason for this, I will mention this significance, is because the capillary, this is where we're going to have gas exchange. This is where we want rapid diffusion. And if you remember, we were talking about the different types of transport, diffusion, osmosis, active transport, right? Diffusion is much quicker the thinner surface you have. So it's basically, it has less, it doesn't have to go through a thick number of layers to go from the blood to the tissue. You imagine something trying to diffuse out of the blood here into the tissue. It's probably possible, but it's very difficult, very slow, not very efficient. Here, it's very efficient. This happens to be just another diagram of the artery, and this is a vein. All right. Okay, so let's talk a little bit about kind of the correlation between structure and function. With the large arteries, and we'll just call them elastic arteries. For example, the aorta, we call it elastic. That's because we have that elastic membrane, that elastic layer that's kind of like a rubber band. Significance of that is, like I mentioned, the aorta, for example, is very close to the heart. When the heart contracts, it pushes blood under a tremendous amount of pressure into that aorta. To accommodate that pressure, the aorta needs to expand during systole as blood's being pumped to it, and then recoil or constrict during diastole to push blood downstream. This is really important in people who have a condition known as atherosclerosis, or you've heard of hardening of the arteries. The elasticity is no longer there due to a variety of plaque buildups and things like that. And so the heart can no longer expand, and that allows the pressure to build up. So you want that elasticity. If we take a look at the arterioles, remember the arterioles are smaller, right? But proportionally, and it might be hard to tell from that last diagram, compared to arteries, they have a higher percentage of smooth muscle compared to arteries. They're percentage-wise, there's more smooth muscle just because they don't have that outer layer, the tunica externa. The significance for that is that this is the blood vessel that undergoes a lot of constriction and dilation with blood pressure changes. So for example, as blood flows through your body, after it's passed through the arteries, goes to the arterioles, these vessels will constrict or dilate depending on how high the pressure is. If the pressure is too high, the arterioles will change their diameter. If it's too low, they'll change their diameter. So they basically have the ability, we like to think of them as really like a regulator. They're the downstream regulator that ensures that the blood pressure is not too high or too low by the time you get to the tissues, by the time you get to the capillaries. So it kind of regulates, is a regulator. And also the speed that blood is flowing through the arterioles is reduced, the velocity, compared to the arteries. The decrease in velocity is also significant because you can imagine blood flowing to the capillaries. It's kind of like getting on or off a bus. Imagine if you want to get off the bus, but the bus driver doesn't slow down, right? It's going to be hard for people to get off the bus. It's also going to be hard for people to get on the bus. By slowing down, it allows more oxygen to get out, more CO2 to get in. So it allows for efficient gas exchange. This is kind of a picture showing how the arteries or the aorta, for example, changes during systole and diastole. If you look at this dashed representation, this is the normal size of a ventricle. When the ventricle contracts, obviously it gets smaller, squeezes blood into the artery through the valves. This is the normal size of an artery. And as like I mentioned before, the artery will expand. Very important. Expands to accommodate the pressure. This is during systole. Then during diastole, basically it shrinks back down or constricts. That allows blood to be pushed downstream. So this expansion accommodates the pressure. The constriction allows for blood to be pushed downstream into the rest of the circulatory system. All right, so what we're talking about here is we're talking about blood flow. Now we're going to talk about some equations that are very important describing blood flow. And it's interesting because the equations are not just relevant to physiology, but they also apply to engineering. Say if someone's designing pipes, for example, or ducts or things like that, they often look at the diameter of a pipe and how much air or how much fluid water is going to go through. One thing that's clear is that any sort of flow through a vessel, so we'll talk about biology now, any flow through a vessel is determined by the resistance to the flow. So when we think about resistance, resistance is something that impedes flow, that makes the flow more difficult. And one of the things that can impede flow, as you can imagine, would be the diameter of a vessel, right? It's going to be easier for blood to flow through if you've got a large diameter. So let's take a look at these diagrams here. This is just a random number. Say the blood flow through this vessel is about 4 liters per minute. And then it branches out into these 4 arterioles. But the arterioles are about the same diameter. So if we divide the flow through each of them, it's about 1 liter per minute. Nice equal, which adds up to 4. If we take a look at what happens if one artery is constricted, look what happens here. This 4 liters per minute, it's not equally divided. There's less blood flowing through here. So we have a greater resistance here. So less blood is going to go down through here, but to compensate, it's going to increase through the other. So now we've got 1 1/4 liters per minute, 1 1/4, 1 1/4, and only a quarter here. So this shows the inverse relationship between flow and resistance. The greater the resistance, which would be a reduction in the diameter, we're going to have less flow. So that's one aspect of resistance. And if you think about it, if you've got water going through a hose and you squeeze the hose, right, or crimp it, the flow is not going to be as great. That's kind of comparable to the change in diameter of a blood vessel. All right. So we're going through the different blood vessels. Let's take a look at the smallest one, which are capillaries. And those of you guys that were taking anatomy, from me anyway, we talked about the blood-brain barrier. So this kind of comes into play here. But before we get to that, I do want to say that capillaries, of course, are the smallest blood vessels. They're one endothelial cell or one simple squamous cell thick. Blood flow is very slow, and this is where gas exchange occurs. This is the spot. Now, having said that, it's important to recognize that there's more than one type of capillary. And the different types of capillaries differ based upon the leakiness of it. So what do I mean by that? The first type of capillary is called a continuous capillary. And here we have endothelial cells that line the capillary, but these cells are joined by tight junctions, which is kind of like a glue that holds the cells together. What does this mean? This means that it limits the ability of large molecules to pass through, right? We're really restricting. I mean, certainly things like oxygen and CO2 can get through. Small molecules, maybe even glucose can get through, although it's difficult, but we don't allow large molecules, large peptides, proteins can't get through. We see this type of capillary at the muscle, the lungs, but probably most importantly, the central nervous system, because this is where we have the blood-brain barrier, where we're protecting the brain against the influx of large molecules that might cause a fluctuation in conditions in the brain. So we want to keep things relatively stable. So we're not blocking everything from getting through, but we're really limiting it to really small molecules. It's called continuous. The next type of capillary is called fenestrated, and it's called fenestrated because we have these little pores, which are known as fenestrations, which allow larger molecules to pass through. You can kind of see it here. Kind of looks like Swiss cheese. We see this primarily in areas where there's a lot of secretion, a lot of absorption, places like the kidneys, where there's a lot of filtering going on, the endocrine glands, where we have hormones being produced, as well as the intestines, where we're absorbing nutrients. So this allows larger molecules, peptides, proteins to kind of squeeze across. Finally, we have the discontinuous capillaries, also called sinusoidal. And this is only found in areas that are associated with hematopoiesis. So that was a lecture from last time, Cardiovascular 3, where we spoke about blood formation, which occurs primarily in the bone marrow, lesser extent in the spleen, and of course, before we're born, during fetal development, it's in the liver. These are very leaky capillaries that are so leaky that it actually allows cells to go into and out of the capillary. That normally doesn't happen. Cells cannot get out of the capillary here. Cells cannot get out here, but here they can. And it makes sense, especially if you're looking at a hemopoietic or a blood cell forming organ. You want, once the cells are formed, to be able to move across the capillaries. All right, so we're talking about capillaries, and one of the things that I mentioned about capillaries is the fact that they're small, and the blood flow is very, very slow, much like it is in the arterioles. And we want the blood flow to be slow because that's going to allow for a much more efficient exchange of gases, right? So this is a diagram which kind of illustrates the relationship between velocity and cross-sectional area. So what does that have to do with anything? Well, one of the reasons why blood flow is so slow through capillaries is we've got a lot of very, very small capillaries, basically 40 billion capillaries. So apparently somebody figured that out throughout the whole body. 40 billion capillaries means that we have a very large cross-sectional area or a surface area. There's a strong relationship between surface area and velocity. In the case of capillaries, the greater the surface area of these small little vessels, the slower the velocity. We're going to be taking a look throughout this abbreviated semester at different aspects of surface area, in terms of the intestine, how with increase in surface area that affects absorption. We're going to take a look at surface area with the lungs. But in this aspect, surface area of the capillaries is a very strong relationship between a high surface area in the capillaries and a decrease in velocity, which is what you want. All right. So we're still at the capillaries. So one of the interesting things about the capillaries, if you think about it, I mentioned that there's an exchange that's going on here. And the exchange involves movement of oxygen and nutrients from the capillaries to the tissues, and movement of waste from the tissues back to the capillaries. So how can you have this two-way mechanism? How can you have this, in the same vessel, how can you have this two-way movement? Well, it's all related to pressure, right? As we've learned from the heart, pressure plays a very important role. There's two main types of pressure that we're looking at in the capillaries. What's called hydrostatic pressure, which is the pressure exerted by the blood coming into the capillaries, right? We call hydrostatic, or it's basically blood pressure. The more blood, the higher pressure coming into the capillaries is going to lead to a greater hydrostatic pressure. The higher hydrostatic pressure is going to tend to drive fluid or gases out of the capillary. It's going to push them out. We also have what's known as osmotic pressure. You guys know all about osmosis, where we spoke about osmotic pressure, which, remember, that's the pressure exerted by particles, solutes, that tend to draw fluid in that direction, in the direction to try to dilute it out. Remember when we're talking about, for example, saltwater fish, the danger to fish, of course, that live in salt water is to become dehydrated, because water is going to tend to go in the direction of the greater osmotic pressure, which is where more solute is in the water. Okay, so we have these two different blood pressures. Well, at this end of it, this is the arterial end. So if you take a look, blood's coming in here, and then it's eventually leading to the venules out here. So we call this the venous end. We call this the arterial end. So blood's coming in here. At the arterial end, the hydrostatic pressure, which is this one in blue, is greater than the osmotic pressure, which is this pi capillary. What does that mean? That's the osmotic pressure. That means that the pressure is greater to drive the fluid out than it is to pull fluid in. As a result, we get what's called net filtration. Blood is going to leave the capillary at the arterial end. As we go through the capillary, eventually everything's balanced, but then as we get at the venous end, as we've lost a lot of fluid, what we still have are particles in the vessel. So at the venous end, the osmotic pressure is actually greater than the hydrostatic. So the pressure that pulls fluid in exceeds the drive to push fluid out. So this is where we have absorption. So filtration, which is the movement out at the arterial end, absorption is pulling fluid in at the venous end. And this is this is basically how it works. It's quite a fascinating mechanism. And again, feel free to ask me any questions if you've got them.
Professor, could you
Yes,
explain again what the hydrostatic pressure is?
sure. So hydrostatic pressure is the pressure exerted by the blood as it's entering into the capillary.
Oh, so pressure inside is what makes things want to go outside.
Yes, so if you think about it, yeah, we've got all this blood in here, and think of it as kind of blood is kind of being squeezed to go out of the capillary. That's the hydrostatic pressure.
Okay, thank you.
Sure. All right, now let's take a look at the veins. All right, so with the veins, we're now on our way to the heart. I'm kind of skipping the venules right now. I don't have a good picture of them. Just know that the venules are just a very small vein. One thing that's interesting is if you look at the blood in any part of the circulatory system, in the arteries, arterioles, capillaries, venules, and veins, at any given time, there's more blood in the veins, which this is going to bring out the importance of venous return that we'll talk about shortly. As I mentioned before, veins have very little muscle. Kind of hard to tell here. This is an artery, this is a vein. It's a little bit less, but they definitely have much less smooth muscle, and they don't have any elastic fibers. So it kind of makes sense because the blood, by the time the blood reaches the veins, the pressure is much lower. So why have muscle or why have elastic fibers? But there's one important element here. We still have to get the blood back to the heart. We've got to have enough pressure to push it back. The pressure is very low in veins. So unless we've got a way, which fortunately we know we do, that's going to push blood back to the heart, we would get a buildup of fluid, especially in our legs. The blood would stay pooled down in our ankles, which some people it does, but that's more of an issue maybe possibly with valve problems that we'll talk about. So the pressure in the veins is very, very low. So how do we ensure blood gets back to the heart? A couple ways. One is, well, first of all, the whole concept is known as venous return. And as much as it's important to pump blood out through the arteries, we can't pump blood out through the arteries if we don't have a lot of blood coming back into the heart, right? So this is called venous return. This is made possible by the skeletal muscle pump, which is technically not a pump, not a new structure. It's just the tendency of skeletal muscle. When it contracts, it squeezes the veins. And when it constricts the veins, right, it forces the valves, which are in the veins, open. Well, this could be a problem because when it squeezes the blood can go up and it can also go down. Well, fortunately, they're one-way valves, so the blood cannot go down really at all, very little. It's going to force the superior valves open. So this is one way to ensure this repeated contraction that occurs to help to kind of ensure blood gets, it's kind of like a milking aspect. If you think of cows like milking an udder, it's kind of a way of ensuring the blood flows back to the heart. I mentioned the role of valves. Well, if the valves are working, it's not a problem. But if someone has a varicose vein, the valves don't close. So when the muscle squeezes the blood goes up, but it also goes down. And that's why people who have varicose veins have often swollen legs, swollen ankles, and because of that pressure, it can be very painful. All right. Then we have the respiratory pump. And this is actually a topic I mentioned, I think, in the last lecture, the one before that, but it's kind of worth revisiting. The respiratory pump is and this kind of illustrates the relationship between the respiratory and the cardiovascular systems. Every time you breathe, you're helping your circulation. when you breathe, your lung volume will increase. This is something we'll cover later on. When your lung volume increases, this also causes an increase in the size of the atria. One of the things we know is that there's an inverse relationship between pressure and volume. So if you increase the volume of a structure, it's going to decrease the pressure on the walls. When you increase the volume or the size of the atria, that decreases the pressure. That's going to drive the blood, help almost like a suction, will pull the blood up from the lower extremities towards the atria. So it's a pressure gradient. So we've got three main things that are going on here. We've got the valves, well, we've got the skeletal muscle pump, we've got the respiratory pump, and of course, all of this is made possible, of course, with the valves. So this is all going to drive blood up, overcoming gravity, because gravity is a problem, especially obviously in your legs, right? We're bipeds, and you've got low blood pressure in the veins. It's actually about 2 millimeters of mercury, whereas blood pressure in the arteries is about 100. So if you're looking at moving blood from high pressure to low pressure, it's really low in the veins. You're not going to move it back unless you've got this ability to squeeze the veins with the skeletal muscle pump and sort of suction the blood up through the respiratory pump. Rati, that's my dog. All right. Now, one thing I want to mention too, and this is not directly related to the cardiovascular system per se, but it's not part of it, but it parallels it. One of the things that I've mentioned is, of course, and you look at this diagram, is blood flows. Once blood pumps out of the heart through the arteries and arterioles, reaches the capillaries, right? The gases and the fluid leak out of the capillaries to the tissue, right? Go to the tissues. And then, of course, oxygen and waste material goes back into the capillaries and then goes back up. Well, unfortunately, it's not that easy. Typically, there's more fluid that leaks out of the capillaries into the tissues than goes back into the capillaries. So we typically have a fluid excess that can accumulate in tissues, what you would call like edema. Fortunately, we have a backup system, which are called the lymphatic capillaries. They pick up any excess fluid that was not returned back to the capillaries, and through a system of vessels called the lymphatic veins, they eventually carry that back to the heart. So the lymphatics are basically a drainage system that allows any excess fluid in tissues to be absorbed back and returned to the heart. Now, if there's an issue with the lymphatics, there's a condition called lymphedema, where there might be an inflammation or some sort of malfunction of the lymphatics. This can also result in swelling of the legs, and that can be very painful, difficult for people who have it. All right, so that takes us through the different types of blood vessels as far as structure and general function. I want to take a look now to kind of expand on that equation that I mentioned before when I was talking about how blood flow is inversely proportional to resistance, right? And I mentioned the example that when you, makes sense, when you squeeze a vessel, right, blood is not going to be able to flow through as well. And this is because of resistance. And that's one example of resistance. So we're going to take that information and plug it into what's called Puiseuil's law. I don't know French, so some of you guys, I believe that's how you pronounce it, Puiseuil's law. This is an equation that looks at the relationship between flow and resistance. So if we take a look at the overall equation before we get into the specifics, first of all, one thing we already know, of course, is that blood flow is inversely proportional to the resistance. The greater the resistance, for example, constricting a vessel, right, is going to decrease blood flow, and vice versa. If we dilate a vessel, reduce the resistance, that's going to increase it. We also know that blood flow is proportional to blood pressure. The greater the blood pressure gradient, the greater the blood flow is going to be. So if you've got, is on the next diagram. Yeah, I'll jump to this for a second. If you want blood to flow in this direction, the pressure up here better be greater than the pressure down here. That's what's going to drive it. And that's kind of how blood flows through the heart, right? You've got to have the pressure greater in the ventricles before it flows into the arteries. So it's proportional. Let's take a look at some other details of that equation. And some you'll be familiar with, but some new terminology. Blood will flow. It'll flow in the direction we want if a pressure gradient is present, delta P. That means there's a difference between P1 and P2, right? P1 is greater than P2. That's going to result in a blood flow. Blood flows from areas of high pressure to low pressure. You guys know that. Blood flow is opposed by the resistance of the system. So we already know that resistance, one aspect of resistance is blood vessel diameter, but there's other parameters as well. One, of course, is the radius or the diameter of the blood vessel. Another one is the viscosity of the blood. So viscosity kind of has to do with the thickness of the blood. So if you think of a substance that you've seen or worked with or experienced that has a high viscosity, what would be an example of something that's very viscous? Anybody? Something like oil or honey. If you look at how those pour, right, there's a lot of viscosity. Well, if you imagine if your blood was like that, right, it wouldn't flow as well. So if we take a look at this, if we have a very small radius, that's going to provide greater resistance and reduce blood flow. If we have blood that's very viscous, that's going to provide a high degree of resistance, and that's going to reduce blood flow. Thirdly, and one we don't think about, is the length of the system. The longer the blood vessels are, further down towards the end of them, this will also cause resistance just because of the blood vessels getting smaller and smaller. Blood flow is not as good. All right. So we have seven conditions here. We're just going to mention the first four. So first five rather. That flow is usually expressed in liters or milliliters per minute. So kind of like when we're talking about cardiac output, remember cardiac output is the amount of blood that's pumped out of a ventricle per minute. In this case, this is the volume of blood that goes through the vessels per minute. Okay, so taking all this, you can see that blood flow is proportional to delta P over radius. If we plug that into an equation, this is the full equation for Puiseuil's law. And there's a couple interesting numbers here. Flow is equal to the change in pressure, that's the delta P, times pi, pi is just a constant, times radius to the fourth power. In the denominator, we have the length and the viscosity times 8n. N is just the number 1. So you would basically say 8 times length times viscosity. So looking at this, if you look at kind of numerator and denominator, the greater the change in pressure, since it's on the numerator, that's going to increase flow. The greater the length and viscosity, there in the denominator, that's going to decrease flow. Radius to the fourth is very significant. This is probably more than any other parameter, this contributes the most to blood flow. And if you take a look at it, let's say the radius is 1. What is 1 to the fourth power? Anybody?
1.
Thank you.
What?
All right. If we double the radius, make it 2, what is 2 to the fourth power?
16.
16, right. So think about that for a second. You double the radius, that's going to cause a 16-fold increase in blood flow. I mean, that's huge, right? So, I mean, not to minimize the significance of these other parameters, but radius is really a factor. And this especially comes into play if somebody has plaque buildup in their blood vessels, right? That's why it's really important to keep up your cardiovascular health. All right. So I found a couple of these diagrams on the internet, and I thought it was pretty relevant. Some of the units of measure are kind of old school. We really don't use cubic centimeters, so kind of ignore that. But let's just take a look at kind of how this equation plays out. Assuming the flow is 100, right? If we double the length of a vessel, the flow, because remember length is on the bottom, we're going to half the flow rate. If we double the viscosity, because that's on the denominator, we're also going to half the flow rate. If we double the pressure gradient, so the difference in pressure between P1 and P2, we're going to increase flow rate. We're going to double it. But look what happens when you double the radius. The flow rate increases 16-fold. Now, the reality is this is in a small vessel, right? If you look throughout the whole body, if a single vessel doubles in size, it's not going to affect, it's not going to, the flow rate's not going to increase 16-fold throughout the whole body, right? This is just kind of a localized thing, but it's still pretty interesting. Expanding on that, let's take a look at the pathological aspects of this. So here we've got a nice healthy artery, no plaque, assuming we have a flow rate of 100. So one of the things about our blood vessels and our body in general, right, they're always trying to achieve homeostasis. So if there's some sort of disruption, they try to compensate. This person has a healthy artery, their blood flow is 100, say their pressure difference is about 120, just randomly. Say they've got a 20% buildup of plaque in their arteries. This is going to reduce the flow rate to 41, which is going to increase the pressure that needs to increase to reestablish the normal flow rate is 293, which is not really compatible with life, right? You won't want that.
Is
Look
that
what happens.
two?
What's that?
Is that 120 and 293? Are those the numbers we see on top when we take blood pressure?
Right, exactly. So that would be the systolic.
Okay.
Yeah. Look what happens if your blood, your arterial diameter or radius is down to 50%. Look what happens to the flow rate. In order to reestablish the flow rate back to 100, this is what your pressure has to be. And obviously this is not going to happen, right? So this is why sometimes people will have, obviously can lead to a heart attack or stroke, because the body cannot increase the pressure that high. So this really is, like they say, a picture's worth 1,000 words. This really illustrates why we need to keep our cardiovascular health, because yes, the flow is decreased, but our body is trying to reestablish it, and it's putting too much of a workload on the actual heart. All right. So let's talk a little bit more about pressure, and just some terms that I think these are discussed in one of the PhysioX exercises. But anyway, so whenever we talk about pressure inside an artery, another way we can describe it is we call it mean arterial pressure. This is the pressure at any one given time in an artery. So this could be, for example, the aorta. Think of this as the left ventricle. This is meant to be like a piston, right? Pumping blood out. This is blood in the left ventricle being squeezed into the artery. And this is blood eventually leaving, going into the arterioles. So we have pressure inside an artery. The pressure inside an artery is governed by two main factors: cardiac output and, once again, resistance. So what does this mean? Well, say if we're looking at this region right here in the artery, it kind of makes sense that the more blood you've got pumping out of the heart into this artery is going to increase pressure. So there's a direct proportion. As we increase cardiac output, we're going to increase pressure. This is kind of like the input. Now here we've got the outlet, right? That blood's leaving the artery and going into the arterial. Well, if we constrict this arterial, reduce the diameter, that's going to make it more difficult for blood to leave. That's going to increase the resistance. So that's going to keep more blood in here, and that's going to increase pressure. So what does this mean? What does this mean? Rye, can you take her down, please? Arterial pressure is going to increase if the blood flow going into the heart, from the heart into the artery increases, and also if you reduce the outlet. So you're putting too much pressure. Now, having said that, that doesn't typically happen. Typically, the greater cardiac output you have, say if you're exercising, you're going to get a proportional increase in the arterial diameter, so your pressure is going to stay normal, nice physiological. But say, for example, you've got buildup of plaque in here, the arterial diameter is decreasing. That's going to make it more difficult for blood to go into the arterial, so it's going to cause a buildup. So arterial pressure is proportional to cardiac output and resistance. And this is going to come into play shortly when we talk about the effect of the autonomic system on mean arterial pressure. All right. Blood pressure. So we have this mean arterial pressure, right, that's in the arteries. And of course, as we know with so many things in the body, we have to have ways of regulating things, right? We maintain homeostasis. And I think I mentioned the first week that we have ways that if our blood pressure goes too high, we have normal mechanisms that will bring it down. If it gets too low, we have ways of bringing it up. The way this is governed is by specialized groups of cells called baroreceptors. We've heard of receptors before. In this case, these are specialized cells that are sensitive to pressure, and they're located in the aorta and in the carotid artery, which is a branch off the aorta. So think of these as little sensors, much like we have like a thermostat, right, which in our house, which senses temperature. These are little specialized cells that sense pressure. And depending on what the pressure is, they report this information back to the brain. And depending on what the pressure is, this will either activate the sympathetic system. If the pressure is too low, we want to increase it. Or if the pressure is too high, it'll activate the parasympathetic to decrease it. So let's take a look and see how that happens. So first of all, what happens if blood pressure goes up? All right, if blood pressure goes up, the baroreceptors will start firing electrical impulse that will travel to the medulla. Very simply put, the response in this case is to activate the parasympathetic system to inhibit the sympathetic. So by inhibiting the sympathetic system, we're going to decrease the force of contraction, right? And we're going to cause vasodilation. Now, going back to this picture, if we increase the diameter of this vessel, that's vasodilation. So by reducing the sympathetic activity, we're going to reduce the output. We're going to increase the diameter, which is going to reduce the resistance. Okay, and that's ultimately going to decrease blood pressure. Okay, sorry about that. My son should have been taking my dog out. Anyway, so that's what's happening with both a decrease in sympathetic output and also parasympathetic. So if we decrease the sympathetic, we're going to get a decrease in the cardiac output, force of contraction. We're going to get a vasodilation. We're also going to get a decrease in heart rate. which is going to be due to both a decrease in sympathetic activity and a corresponding increase in parasympathetic. So there's a lot of stuff listed here. Basically, at the end of the day, what you guys need to remember that in response to high blood pressure, there's a decrease in sympathetic output, increase in parasympathetic, which ultimately is going to lead to a decrease in cardiac output, decrease in resistance, which is going to lead to a decrease in blood pressure. Any questions on that?
Dr. Crown, I have a question.
Yeah.
So someone who cannot control their blood pressure, this doesn't apply, correct?
That is correct. So for some reason or another, there's different causes. Right. There are some people that have what's called essential hypertension, that their normal mechanisms aren't working properly. So that's why that many times they have to take certain medicines like ACE inhibitors and other things that are going to compensate and help with this. Yes.
Gotcha. Thank you.
Sure. All right. So what happens if someone has low blood pressure? One example of low blood pressure is orthostatic hypotension. That's a fancy name. All it really means, say you're lying down in bed, your alarm goes off and you stand up really quickly. I'm sure everyone's experienced that. You're kind of off balance at first. That's because there's a decreased blood flow to your head and everything like that. So there's a drop in blood pressure. When there's and this can happen in other examples of hypotension as well. But anyway, no matter what the cause, when blood pressure decreases, this results in a decrease in activity of those baroreceptors. And that, even though there's a decrease in activity, that still sends a signal back to the brain that says, okay, I'm not getting much of a signal, so that must mean that pressure is low. So that's going to correspond to an increase in sympathetic output and a decrease in parasympathetic output, which is going to lead to the opposite. We're going to get a increased force of contraction due to the increase in sympathetic output. We're going to get a vasoconstriction, right, which is going to make it more difficult for blood to leave the arteries. It's going to cause a buildup of pressure, and we're going to get an increase in heart rate. So increased cardiac outputs by these two, increased resistance, and now we're going to get blood pressure back to normal. Now, really the big story is this is always going on during the course of the day. You know, if you were to measure your blood pressure in the morning versus afternoon or evening, I could almost guarantee that it's not going to be the same each time. And there's this constant interplay between the sympathetic and parasympathetic system that are basically constantly adjusting. But like the one question out there, there are some people that even with this beautiful mechanism that normally works, there are some people due to a variety of conditions, whether it's a cardiac condition or more systemic, even kidneys, for example, this can actually lead to a condition where this mechanism is not working. And so there needs to be some sort of a pharmaceutical intervention, maybe, where you have to take some medication. All right. So what we just spoke about was kind of like the immediate response to blood pressure changes, right? But there's also more of like a long-term response. And this is actually the role of the kidneys. If you take a look at this picture, and this is the response to high blood pressure, we already know that with if the blood pressure goes up, the cardiovascular system is a very fast response that will decrease cardiac output. It will increase the diameter of blood vessels, which will make blood flow much easier, and that will reduce blood pressure. But then we have a slower, more of a sustained response for a while, and that's the kidneys. If the pressure is really high, that will lead to an increase in excretion. And you remember that hormone we spoke about a while ago? We'll talk about it again, I think, with the endocrine system, ANF or ANP, atrial natriuretic peptide. This hormone goes up during high blood pressure, and causes the kidneys to excrete more fluid and salt, which will also lower the blood pressure. So this is kind of a neat early and delayed response, and we have a lot of these. Even our stress response is actually, we have an early and then a chronic. So this is two aspects of the response to blood pressure, both cardiovascular and renal or kidney. All right. The final frontier. So the last thing I want to talk about is hemostasis. Sounds a lot like homeostasis, but it's not. It's hemostasis, which is the process of blood vessel repair, which includes clotting. This is actually a blood clot, a normal one. And here's, you can see these are red blood cells, and these are what we call fibrin. It's a fibrin meshwork. That's part of that. So what I want to spend a little time talking about is the mechanism of how a blood clot forms. Now, what we're talking about here is a physiological blood clot, right? There are also blood clots that are formed inappropriately, say in our blood vessels, and this is due to some sort of injury, right, in our blood vessel due to plaque buildup, and that leads to a blood clot. In that case, that's maladaptive, right? When you have, someone has a clot inside their artery, right, due to plaque buildup, that can lead to devastating consequences due to, blockage of blood flow. What we're talking about here is the physiological response. Normally what happens, say, if you cut a blood vessel, you injure yourself and you bleed a little bit, that whole process, okay? So first of all, the purpose of it is to minimize the amount of blood loss from your blood vessels, all right? So there are 3 steps to hemostasis. First one is kind of like, I like to think of it as like the first responder. This is where there's an immediate vasoconstriction where the injury is. Now, of course, you're still going to lose some blood. This is normal, but the vasoconstriction is meant to at least reduce the amount. That's kind of the first thing that occurs during hemostasis. This is followed by what we call platelet aggregation. And in the last lecture, I spoke about platelets. These are the cell fragments that are responsible for producing chemicals that lead to a clot, right? We get a buildup of a aggregation of platelets at the injury. So this is the site of the injury. And this forms kind of like a plug. I like to think of it as almost like rubber cement. It's kind of like a temporary seal. This is not the clot. This is like a temporary seal until a clot is eventually formed. So for the next several slides, we're going to go through this process in some fair amount of detail. All right. So first of all, normally what happens is our normal blood flow, we have normal blood flow, our blood does not clot, right? We don't want our blood just to clot randomly. Platelets do not normally stick to the blood vessel. So why is that? Well, normally there's several different chemicals that are produced, and I apologize for all these names, but it is what it is. We have a chemical called prostacyclin, PGI2. We have a molecule called nitric oxide. You remember that from our discussion on the nervous system, but it's also produced here. And a molecule called CD39. They all interact along with the platelets, which convert ADP. Remember, we spoke about ATP, and we know, of course, that in mechanisms such as muscle contraction, right? ATP is broken down to ADP and phosphate, generating energy. Well, platelets, the ADP that's inside them, it's converted to AMP. So what does that really mean? All these different conditions, the production of prostacyclin, nitric oxide, CD39, and AMP, inhibits the ability of the platelets to stick together, and it also promotes the blood vessels to be dilated. Those are 2 types of conditions that you want in a healthy blood vessel, right? You want the blood to flow through smoothly, and you don't want the platelets to be sticky. And that's what's in our vessels normally. What happens when the endothelium or the tunica interna, I'll say, is damaged? So if we go back to the previous slide, this is like a normal simple squamous cell. Oops. This is what happens when it's damaged. Kind of an extreme case, but it's no longer there, right? So what happens when there's damage at this endothelium? This triggers the platelets. They get very excited. They get very excited and they go right to where that injury is. And they stick to collagen. Collagen is actually in some of the underlying tissue of a blood vessel. Platelets do not normally see collagen, right? In an intact vessel, there's the collagen there. You don't see it. They don't see it. But once this is removed, they see it. And when they get excited, a couple things happen. There's a production of a chemical called von Willebrand's factor that triggers the platelets to come to the injury. It's kind of like an invitation. It's like, okay, come on over. I need you to take care of this. So von Willebrand's factor that's produced causes the platelets to migrate over here. Once the platelets migrate over here, that AMP that they were producing is now converted to ADP, and they produce thromboxane, and they also produce, which isn't shown here, serotonin. Interestingly, serotonin is produced all over the place. In this case, what does it mean? All these different substances, ADP, serotonin, and thromboxane, lead to vasoconstriction. Remember, that's the first thing that happens right there, vasoconstriction. But they also cause the platelets to accumulate and become very, very sticky. Platelets weren't sticky over here. They're just floating through. Over here, they're now sticky, and which means they not only stick to the collagen, but they start sticking to each other. This ultimately leads to platelet aggregation, and it's kind of like a tongue twister thing, but sticky platelets attached to the collagen, which the platelets then produce other chemicals to bring more platelets in. It's kind of like it's a positive feedback is what it is. The platelets that are sticking now draw more platelets in the area. Next thing you know, you've got this rubber cement seal, this platelet plug that's sealing the gap, which is great. That's what you want, but that's only temporary. What you really need is you need just more than platelets. You need to form a clot. And a clot is a very detailed process. We're not going to go through all of it, but basically I can tell you that it involves an enzymatic reaction, several different enzymes and clotting factors. At the end of the action of all these enzymes, normally a soluble protein in the blood called fibrinogen is converted to fibrin, which comes out of solution and is insoluble. That leads to a mesh, like you saw on the first slide from the hemostasis description. I can go back really quickly. Oops, like right there. That's this fibrin mesh. In that mesh, we also have, we've got the mesh, we've got platelets, and we've got red blood cells. That all makes up a clot. So let's take a closer look at this enzymatic reaction. Like I mentioned, I'm just going to go through it kind of just very general. So first of all, there's obviously a lot listed here. What I want you to know, there's a lot of different factors. All I want you to know is this, is that there's a factor, not very descriptive, that's produced by these platelets called factor 10. Even though it says factor X, that's factor 10. Factor 10 activates an enzyme called prothrombinase. Prothrombinase is an enzyme that converts prothrombin into thrombin. Thrombin itself is an enzyme that converts fibrinogen into fibrin. And that's really the final step in clot formation. Don't worry about these other factors out here, 7 and all these other things. Just focus on from factor 10 down. Okay, so I want to show you a quick little video that goes into a little bit more detail, but don't worry about the extra detail. Just kind of focus about what we went over here. Let me see if I can get this to work for a second. Let's see, hopefully it will work. Let's see here. Oh, I did it twice. Let's see. Okay, and oh, you know something? Crap. Okay, hold on one second. Sorry about that. All right, if you bear with me 1 second, I'm gonna go out of this. I'm gonna stop the share for a second. I'm gonna go do something really quick. I'm gonna go to our Canvas page. Let's see. And I think I've got a video on the Canvas page, actually. And yeah, I believe it's on. Let's see. So I'm going to go to this for a second. Let's see if you guys can actually, oops, they're there. Let me go to share screen. Okay, so now we're on the Canvas page. If you scroll down the Canvas page, way down here under videos, here is a video of hemostasis. Let me see if I've got it here. All right.
Your people are spread thin.
Hold on a second. Let's see. Let me hold on 1 second here. Hold on. Sorry about that.
Bluescape enables corporate leaders to secure this critical data
Stop
and
share.
content together through a single pane of glass.
Let's
So
see.
you can get
Share
more
screen.
decisions faster. Bluescape. Together from anywhere.
Here we go.
Hemostasis is the process that controls bleeding at the site of injury. Blood loss is stopped by formation of blood clots that seal the breaks in blood vessels. Hemostatic mechanisms involve small cell fragments known as platelets and a dozen of soluble clotting factors. These elements are always present in the blood in their inactive form, ready to activate, typically within seconds of an injury. When blood vessels are damaged, blood is exposed to components of the surrounding tissue.
Collagen.
Some of these components bind to and activate platelets. Activated platelets are involved in all stages of hemostasis. First, they secrete chemicals that induce blood vessels to constrict, thereby reducing blood loss. This is known as vascular spasm, the most immediate response to tissue injury. Vascular spasm is also triggered by local pain receptors and by substances released by endothelial cells. Second, activated platelets become adhesive to each other and to the endothelium. They clump together, forming a platelet plug. They also secrete substances that attract other nearby platelets, activating them in a positive feedback loop, speeding up the formation and propagation of the plug. Third, the surface of activated platelets serves as the site for coagulation, the formation of blood clots. A clot is essentially a platelet plug reinforced with strands of a protein called fibrin, the final product of the coagulation cascade. Coagulation is a complex chain reaction where one clotting factor activates the next in the multi-step pathway. There are two activation pathways for coagulation. The extrinsic pathway starts with the exposure of blood clotting factors to the tissue factor, TF, in the extravascular tissue. This pathway is induced by injuries to blood vessels. The intrinsic pathway, which involves only factors within blood vessels, is thought to serve as a positive feedback loop, amplifying coagulation. The two pathways converge into a common pathway, producing thrombin and ultimately fibrin. Thrombin has the central role in the coagulation cascade. It cleaves soluble fibrinogen to generate insoluble fibrin. Thrombin also further activates platelets and initiates a positive feedback loop
Okay.
that is essential for clot propagation.
All right.
Blood clots prevent
So
blood
I'm going to
loss
stop
during
that
wound
actually.
healing.
All right. Okay. So were you guys able to see that okay?
Yes.
Okay, good. Yeah. So like I said, there's going to be a lot of stuff on there that some stuff that we didn't go over. Just focus on what we went over. All right. So let me go ahead and finish stuff here. Stop share. Go back to share again. And we were right there. Okay. I'm getting the hang of this slowly. Let's see. Here we go. Okay. Now, we have clots that form, but also you don't want the clot to stick around very long, right? I mean, you want the clot to stick around as long as it takes for the blood vessel to repair itself. So then when that happens, you want it to dissolve. So what is involved with that? Once a blood vessel is repaired, couple different substances, I wish there was just one, but unfortunately there's several, kallikrein, UPA, and TPA are substances which all lead to the conversion of a soluble protein called plasminogen into plasmin. And plasmin is an enzyme that cuts fibrin, that basically degrades it. So whereas clot formation involves the formation of fibrin into that mesh, plaque dissolution or dissolving leads to the dissolving or the removal of the plaque. So a removal of the clot. So with fibrin, you have a clot. Without fibrin, the clot's gone. All right. So a couple just final slides. We're actually ending about the same time that class does. That's pretty interesting. All right. So we really take it for granted that our blood clots, you cut yourself, you really don't think twice about it. I mean, granted, you might not like to bleed, of course, but you may have to put pressure on it or whatever, eventually it stops bleeding. But if you think about all the steps that are involved, it's a pretty amazing process. The fact that it works most of the time. However, there's a couple other conditions that we call clotting disorders in which people have their blood clotting mechanism is not working. One is called von Willebrand's disease. And this by the name, you can tell it's got something to do with von Willebrand's factor. These people are not producing enough von Willebrand's factor, or maybe not any. It occurs as frequently as 1 in 1,000 people, which seems like quite a bit, actually. I personally don't know anyone that has it, but I've never really asked. But fortunately, people can get injections of von Willebrand's factor periodically to help with that. But the fact that they're not producing it leads to the failure of platelets to adhere to the injury. If you don't have this is really like an old graphic, as you can tell. But if you don't have the platelets adhering, the blood's just going to leak out. There's nothing preventing the blood from leaking because there's no platelet plug. That's probably the most common, at least the last I checked, the most common bleeding disorder. The second one, which has a long history, going back to as early as like the Queen Victoria dynasty, is due to a lack of a couple blood clotting factors called hemophilia. This is an X-linked gene. This is or what's sometimes called a sex-linked gene. This is a condition much like a red-green color blindness, where males are affected. Females do not get the disease, but they can be carriers. So if a female has one gene for it, she'll be a carrier, typically just one gene. If a male has one gene for it, he will have the disease. And I think, yes, this is actually the pedigree. We often call the royal disease because the first time it was going back in time, this is, of course, like a typical genetic profile. This is Queen Victoria, and this is, I guess she was married to Albert back in the 1800s. And obviously there's no way to do genetic testing, right? Back then, they didn't know. But all these different family members over the course of history developed hemophilia or carried it. The square represents the male. The full red indicates that they have the disease. The circle is the female, and they're carriers. So based upon the incidence of hemophilia in all these people, they kind of traced it back that she must have been a carrier. And of course, with royal families, the gene pool is pretty small, right? Because royal family members marry royal family members. You know, the Emperor of Russia was related to the Queen of England, or, you know, different countries. They're different countries, but they're all related. So you have this gene pool that's small, which increases the incidence of hemophilia. All right, so that actually takes us to the end. Let's see here, let me go back to where I can see you guys. Did I lose anybody? Oh, cool, everyone's still here. Oh, let me just take a look at some questions. Sorry about that. Hi, sir, please, I want to know how blood flow through the lymphatic system. I need to see some bubbles on the lymphatic system. What is the purpose of the small bubbles? They're not actually bubbles. Those are actually what are called nodules. Those are found in the lymph node. Those are clusters of lymphocytes that are found in the lymph nodes. I didn't really talk about the lymph nodes, but it's a good question. The lymphatic system drains the fluid from the tissues, and as it's returning back to the heart, it's actually filtered through the lymphatics. So that looks like somebody put that. So, and Toya answered the question for me. All right, nice job. All right, who else? Go, what is the use of lymphatic node in transport of blood? So the lymph node itself is not part of the transport. It's kind of like an assessment station. As the fluid that's drained into the tissues, as it goes back to the heart through the lymphatics, it has to filter through the lymph node. And basically it's kind of cleaned up. Your camera's not off, not to be rude, but just a heads up. Okay. I don't know what that means. Anyway, so were you guys able to see everything okay?
Yes.
Okay, good. All right, so we're gonna stop there. I've got this recorded. I'll be posting this. I'm also just on my own. I'm gonna be recording the first respiratory lecture, so that'll be posted as well. This is Thursday. Sometime over the weekend, I'll be sending you guys a study guide. And then we'll be doing some more respiratory on Tuesday, and then reviewing. I'll also be posting, I know I did send you out kind of a brief quiz. I will be kind of opening that up again, kind of cardio quiz, and I'll be posting another quiz just so you can kind of see how you're doing, how you're, you know, keeping up with all the material. So, any other questions?
Professor, I had a question about the von Willebrand disease and natural system. I was wondering if blood thinners have any like correlation to those systems.
So blood thinners, there's different types of blood thinners. And I know blood thinners, there's different types. I know blood thinners act on thrombin to reduce the level of thrombin, which will affect the formation of fibrin. Whether blood thinners have a direct effect on von Willebrand's factor, that's a really, really good question. And I don't know the answer.
Okay.
Yeah.
Okay, thank you.
That's Emily, right?
Yes.
Okay. Anyone else? All right, so look for an email from me and also some YouTube videos from me over the next day or so, and I'll see you guys on Tuesday.
Bye.
Have a good
Thank
weekend.
you.
Bye, thank you.
Sure.